My name is Ruta Brazauskas. I am faculty in the Division of Biostatistics at the Data Science Institute here at MCW. And I also work for CTSI, Biostatistics, Epidemiology, and Research Design Core. So I wanted to make you aware about our services before we start talking about causal inference. So BIRD provides services in biostats, epidemiology, and research design. Our director is Spencer Huang, faculty at UWM. And it's a collaboration of Zilber School of Public Health at UWM, Biostatistics Consulting Service at MCW, and CAPS in the Department of Medicine at MCW. So what do we do? If you need a little bit of help with statistics, and in particular, this becomes important when you design or plan your studies, write your grants, you can apply for BIRD Mini Grant. That will provide you with 4 to 6 hours of statistical support free of charge. And the common reasons why people apply for these grants and services they ask for include discussions of project aims, of study design. We can review data and work with you on data analysis plan, provide sample size calculation, do short analyses that are needed for study design, and review the results that you may have and prepare to write them up in a manuscript. So in addition to BIRD, if you have more extensive statistical needs, you can always receive those through biostatistics consulting services. And that also includes study design, sample size calculations, grant preps, help with writing proposals, and then all kinds of data analysis, including clinical trials, observational databases, large data sets, and things like that. We do everything from graphics, tables, modeling, dealing with missing data, and from start to finish, from study design to manuscript preparation. Many departments or divisions have a standing contract with us. So that includes surgery, orthopedic surgery, physical medicine and rehab, graded pharmacy, pediatrics emergency, hem-onc at MCW. If you work for one of these departments, you can contact your administrators and ask how to get support for your statistical needs. Otherwise, we will always be happy to provide service for fee. Okay, so now moving on to objectives of this talk. This is the first of several lectures which will be offered this year, and they are all on causal inference. So today's lecture will be just general overview where the causal inference comes from and what it entails. So we will talk about the relationships between variables, about the goals for causal inference, and one of the main goals will involve estimating treatment effects. So how do we do that? And that will heavily rely on causal diagrams, which is an inseparable part of causal inference. I will also give you an overview of future lectures, which will go in greater detail on how we do causal inference in applied settings. So when we have data, we always assume that there is a mechanism which generated it, and that's how nature works, basically. So we will assume that there is such a mechanism which produced the data set that we see. Those data generating processes or laws work behind the scenes, and we may not even know about their existence. And some are well established and well investigated by now. While we cannot see them directly at work, we see the data that it produces, and the data can be collected and analyzed. So we learn about these laws or the rules of nature from doing empirical observations and analysis. So that all involves theory, hypothesis, and research questions, which drive the scientific research process aimed at understanding how things work. So theory means that there is a why or because or a reason somewhere there behind the things that we see. And then a good research question that we formulate takes us from theory to hypothesis, which we will investigate. So a lot of empirical research comes down to describing statistical variables. So what's a variable? You will see that they're mentioned over and over again in many statistical talks and papers, publications. It's things that you should keep in mind when you do your own research. It's just a bunch of observations or a bunch of the same measurements taken on different individuals or cell lines or investigational units. For example, that can be healthcare spending for 1,200 people who live with sickle cell disease. It can be quality of life measures for cancer patients. But when we collect data, we have a lot of these observations, and we cannot make sense of it just by looking at these observations. So what do? We have to summarize them somehow. That involves identifying the type of the variable, and then using appropriate summary techniques or tools to somehow condense that information into a readable or understandable format. A big part of the description will be in the form of describing how different variables interact with each other or what relationship they possess. So when we describe relationship between variables, it's basically aimed at understanding on what learning about one variable tells you about the other variable. Some things are very natural. For example, when we look at height and age relationship among children. So generally, we think the older the child, the taller he is. So learning that we have two children, let's say ages of 13 and 6, will give you a pretty good idea which one is taller, because we know approximate relationship between the two things. So nature of the relationships can be either very simple or complicated or non-existent. So for example, when one thing increases and the other in response increases, we say that there's a positive relationship. So that's the example I just mentioned. So if age increases in children, usually their height increases. So that's an example of positive relationship. There can be a negative relationship. When X increases, the outcome Y will decrease. For example, when you apply a higher temperature to sterilize a surgical instrument, number of bacteria on that instrument decreases. That's an example of a negative relationship. Then the relationships may not exist at all. So you may change X whatever you want and Y will not budge. It won't change. That's an example of non-existent or null relationship. Some relationships are not as simple as just when one increases, the other thing increases. It can be much more complicated. It can be, let's say, for small values of X, Y will increase when X increases. And then suddenly it levels off. And then regardless of X going up, Y will just not change. That's a more complicated relationship, but that can be described as well. And when we talk about the relationships between the two variables, you can always think about a whole set of, let's say, outcomes for a fixed X. So for example, when you look at children who are 6, their height is not the same. It will vary. So that's what we mean by conditional distribution. And you will see that term in some of the lectures related to causal inference as well. So when we hold one variable fixed, the other will vary. And that's important to understand when we describe the relationship between variables. This takes a step further as in describing the relationship between two variables. We usually think about the relationship as describing the association. That is describing a link or a pattern that we see between the two variables. And in many cases, that will be enough. But sometimes we want to say very definitively, X causes Y. And that's a much stronger statement than saying that X is associated with Y. Because causation requires that there is an association, that's a minimum condition that should be present between the two variables. But the reverse is not necessarily true. The association does not imply causation, and you probably have heard this many times. So association between two things can occur with or without a causal relationship. So causal inferences will analyze the response when the cause variable is changed. And we can say that X causes Y if changing the value of X will result in the change in the distribution of Y. It changes the value of Y. Not all the time, but the general, like how often a Y occurs or what values it assumes on average will be changed by increasing or reducing the incoming X or the exposure measure. So when we talk about causation and association, in some setups will be very clear what can be established and what exists and what relationship doesn't exist. For example, if we look at a penicillin, we know that it causes bacteria to die. That's a causation. For example, wearing shorts and eating ice cream is definitely correlated, but there is no causal relationship. Just both of those things happen to be in hot days. So when we see one increasing, we usually see the rates of other things increasing as well. But there is no causal relationship. If you make somebody wear shorts, it's not necessarily that they will start eating ice cream. And the opposite is true as well. Sometimes those relationships are complicated and they involve like far-off variables. For example, if price of cigarettes does not affect health by itself, it may reduce the number of cigarettes people smoke and in turn improve their health. So that's a relationship, but it's not exactly the direct relationship between the price of cigarettes and better health, but one exists. So even if X causes Y to change, not all the time when X changes, we will still consider it as a causal relationship. So why do we do causal inference? Many research questions were interested in are causal in nature. We don't want to know just what happened. We want to know why things happen and that one thing cause a certain outcome. So for example, if we are looking at people who take certain cold medication, we don't want to know that they got better. We almost do know that they will get better eventually, but we want to know if the medicine made them get better quickly. For example, if Medicare stopped paying for a certain procedure and that was followed by a drop in the number of those procedures performed, we want to know if discontinued Medicaid coverage for that procedure caused a drop in the procedures. So that involves causal and non-causal statements. And the same thing can be viewed in terms of both. For example, it was observed that there is an association between being sleep deprived and having higher mortality rate. So we can phrase our question like this: do people who die early also tend to sleep less? That would be non-causal relationship or non-causal statement. Causal statement would be more direct. Does a lack of sleep kill you? So that would be an example of causal statement. And that's what we want to be able to state when we do causal inference. So let's talk about other terminology that you may encounter when we talk about relationship between variables: causal, non-causal. So for example, if we don't imply causality, and you will see these in papers or publications, people tend to say X and Y are associated, or X and Y are correlated, or X and Y are related. X and Y tend to come together or occur or do not occur together, or X and Y go together. Causal relationships have a much more clear direction. So that's the distinguishing feature of causal statements. It means that X is doing something to Y. And it can be expressed in different terms. For example, X causes Y, X affects Y. The effect of X on Y is the following: or X increases Y, X changes Y, X lead to Y outcome. X determines Y, X triggers Y, causes Y, or X improves Y, or X is responsible for Y. So these are all the terms that you will see associated with statements which imply causality. In many cases, people stop short of mentioning causality, but they almost want you to believe that there is one. That can be visible from statements like X is linked to Y, X is followed by Y, or Y is followed by X. X has ramifications for Y. X predicts Y. Or people who have X are more likely to have Y. Y happens as X happens, and things like that. So this have like a hidden implication of causality. So now, when we do causal inference, the aim is usually to identify true cause and effect relationship between factors. Those helped us to understand the impact of intervention or treatment on specific outcomes, and usually examines why behind observed association rather than just what was associated with what. So it is able to distinguish causation from correlation and focuses on interventions and effects. So that's the focus of causal inference. So let's look a little bit on how we estimate causal effect. So suppose there are two possible actions, treatments, conditions, whatever you want to call them, that can be applied to an individual. For a short notation will be 1, which will stand for, let's say, active treatment, and 0 for control, which could be placebo. Then for each individual in the population, we see an outcome associated with that. So if the treatment was applied, our outcome will be Y, and 1 will just, in the parentheses, will mark just the fact that the individual was treated. And if control was applied, we will mark the outcome Y, and just emphasize that it's for a control condition. So then a natural way to estimate causal effect, just take the difference of the two. So if a person receives a treatment and if a person receives a placebo or control, their difference will express a causal effect caused by that treatment. So a natural way to define causal effect will be just subtracting the two outcomes, one observed under active treatment, one observed under a control condition. So let's look at a simple example. So when we look at the causal effects, we have, let's say, 4 individuals, A, B, C, D, and we observe their outcomes, whatever that would be, under 2 conditions: when a person was treated and untreated. So these are hypothetical numbers, let's say 1, 1, 2, 2, and 2, 5, 5, 4. For each individual, we can calculate the difference, and that would be individual causal effect. So for this individual, the difference between 2 and 1 treated and untreated condition outcomes will be exactly 1. This will be 5 minus 1. That results in a causal effect of 4 units. And 5 minus 2 is a causal effect of 3 units. And this is similarly equal to 2. So it is natural to estimate causal effect as the average treatment effect that you observe for these individuals. If we calculate arithmetic average, we will get 2.5. So that's the average causal effect in this population. So, but notice one thing. In reality, what happens? A patient usually is observed just under one condition. Either he got the treatment or he was assigned to placebo. That's the simplest way to think about it. So this column or these measurements in reality will never exist. So this is what we call counterfactual data. So the fundamental problem of causal inference is that for each individual, we only get to observe one of the 2 potential outcomes. So all the unseen information about each individual, which I just showed in the previous slide, is called counterfactual. So what do? We only can use data that we observe. So for treated individuals, we can calculate their outcomes. We can calculate the outcomes for untreated individuals, so the ones who took control treatment, and calculate their difference. So a common way to estimate the average treatment effect, which we think would be a good estimate of our causal effect, would be just take an average outcome among those who were treated and see what that was, and an average outcome who were receiving placebo or didn't get the treatment, and we will think that it's a good estimate for them on what they experience. So the average of these two things will form the average treatment effect, which in turn estimates the causal effect. in the population. So how does that work on that example? So this is the treatment indicator for these 4 individuals. We see that number A and C were receiving active treatment. So that's what we observed, their outcomes under this condition. So 2 and 5. These 2 individuals, B and D, were not treated. They received placebo. Their outcome was, as we saw before, 1 and 2. But everything else is non-existent. These numbers disappear. So we cannot even calculate the difference. So what do? We calculate the average outcome among treated. That will be 2 plus 5 divided by 2. This is 3.5. Similarly, for untreated, that's 1.5. So the difference average in the outcomes between treated and untreated becomes equal to 2. That's different from what we had before, from hypothetical example. So it might be not as good of an estimate as we thought, because in reality, it should have been 2.5 what we got before. That's not exactly matching, but notice what it matches. If you look at the average treatment effect among the treated only, which was 1 and 3, the average would be exactly 2. So these 2 match, and this is not a coincidence. That's the way it is. So now the next natural question will be, when is this a good estimate? So if we are really looking at the difference just of the outcomes between treated individuals and untreated, and for the difference, when is really estimating the causal effect? Well, we will come back to this question in a minute. But when we talk about these things, even by now, you saw that I can estimate several things. Average treatment effect. This slide already showed average treatment effect only among those who were treated. So there are a lot of things that can be estimated or should be estimated from the data. So when we are estimating treatment effects, it's very important to consider the population for which the effect is being estimated. So for example, when we run a clinical trial, and we want to see if a treatment is effective, we can do it a couple of ways. So let's say we want to do it only on patients who really stuck with their treatment and the reassignment. So if those were designed to patients assigned to receive placebo, they were not receiving active treatment, and the ones which were supposed to get the treatment really received it and were adherent to that treatment. But some other people may, or such as like insurance company or a clinician, may be interested in a different population, which would be intention to treat population. And that would be estimating a treatment effect for individuals based on the treatment that they were assigned to receive, regardless of whether they got it or they didn't get it. So the populations might be different, and we have to be very clear about what the study population is in any given setup or any given a clinical trial protocol. In addition to the population, we have to think a little bit about what we want to estimate. So we already saw that a concept of average treatment effect, ATE, average treatment effect among the treated, ATT. There is another thing, there is average treatment effect among untreated, ATU. So all those are legit quantities that we may be interested for one reason or another. So estimates, what we call estimates and causal inference, are statistical quantities. They are derived from the data. And we think that they should summarize the causal effects of the treatment in the target population. So it's important to understand what they are and what they will be in a particular study, because that has implications for interpreting the results and choosing statistical methods to estimate them. Some of those estimations are not really straightforward. And the estimator that we come up with should provide a valid and a good quality estimate of the target estimate or the quantity we want to estimate. So this, so we already saw that we want to estimate average treatment effect, and one way to do it is just taking the difference between the outcomes for treated and untreated. So and in our example, actually the two didn't match. If we hypothetically had the outcomes, the average treatment effect was 2, But when we 2.5, and when we calculated it based on the difference between the outcomes of treated and untreated, that happened to be 2. So there was a slight difference. When would we expect not to see any difference between the two, between the target and the actual average treatment effect, the way we computed? That would hold when there is no selection bias. So this is the reason why randomized experiments are still gold standard in establishing causal relationship. They remove any possible selection bias. So when we look at the people who get treated and those who do not get treated, they are identical with respect to everything else. So if we see any difference in their outcomes, we know that this is because of the treatment they got, but not because, you know, one group was younger, one group was, let's say, less sick. That is out of the picture when we have randomization. Now, observational data will be different. So it doesn't have that randomization. Patients basically assign themselves into treatments. So there are characteristics predisposing patients to get, you know, certain treatments or exposure more frequently. So we can directly make inference about treatment effects if we have experimental data or randomized experiments. But when we have observational data, the data generating mechanism is different. And this is a schematic picture of the two setups. When you have randomized experiment or a randomization in your treatments, you can directly look at the outcome and see if you see the difference based on the treatment. This picture is much more complicated. So in this case, we still look at the relationship between observed treatment and outcome, but there are a lot of noise in there. There are factors which can affect both. They can affect the treatment and how people get. Maybe younger patients choose one thing, older choose a different thing, and things like that. And also the same set of our factors can affect the outcome. So the picture becomes much more complicated in observational data. So this is our randomized setup. This is the observational data. So we have to account for these confounders. So now, while this picture is very simple, in many real case applications, it will become quite complex. So all causal inference will start by thinking about the process which generated your data. So just basically picture the process which leads you from the exposure to the outcome. So we start by thinking about variables which cause each other, or like one variable causes another. Then we think about the relationships. And if there is a relationship between the two, that must be a part of that data generating process which produce the data that you see. You can make lists of these things and describe how they work, but we usually use graphs to depict this process. So what we call causal diagrams are very useful in representing the data generating process and causal relationships which exist within it. So that will allow you to see direct and indirect path, how we can go from exposure to the outcome and how we can explore those relationships. So causal diagram will be just really a graph which consists of nodes, and that will be representing variables that participate in that process. And it will consist of arrows, which shows the relationships between those variables that are involved. One feature that causal diagrams possess is that they don't have cycles. So you cannot loop a variable immediately back to itself. Variables cannot cause themselves. That's why we don't allow for cycles or loops in the causal diagrams. So let's look at some examples. How do we draw those causal diagrams? So first of all, you know, start by making a list of variables. And that can be anything that you think is related closely or remotely to the phenomenon that you are looking at. Start with the treatment and outcome. That's the best place to start, and it usually will grow from that point. Then you think about all the variables that can have a relationship between either two of them, either exposure or the outcome, and some will affect both. Put that on the list. And then you start thinking about the relationships between all those variables that you have on the list. So let's look at a simple example. Maternal deprivation, which is basically poverty in mothers, and whether it causes low birth weight in their babies. So we start building variable list. Our treatment will be maternal deprivation. And just for simplicity, we will just have it as yes or no. Outcome will be having a low birth weight infant. That's also a yes or no outcome. Now, when you think about this phenomenon, how you can transition from maternal deprivation to low birth weight, it can be very direct relationship. Simply, poverty can cause low birth weight. Now, but how does it cause it? We start thinking about other things which can be involved or causing low birth weight or maternal deprivation or be in the path between the two. Things that come to mind, for example, can be age in causing maternal deprivation or be associated with that. It can be child tax policy, for example, more favorable tax policy towards expectant mothers or can have favorable effect on that. Now, when you think about low birth weight, that can be associated with person's age, diet, smoking, and even such genetic factors like maternal height. So we start thinking about these variables and make a list of something that you would like to consider as you talk about cause and effect relationship between maternal deprivation and low birth weight. And then we will start thinking about how they affect each other. So this will be all in the next diagram that I have in my next slide. But when you talk about causal pathways, so think about them. You can think about how one affects the other. So for example, a causal pathway that involves diet might be one that deprivation acts on having a baby with low birth weight. Then maternal age also affects birth weight. And it also can affect maternal deprivation, but cannot be the other way around. Smoking can affect birth weight, and it can vary by age. It's just observed that it's such a relationship may exist, that let's say older people smoke less. But we also believe that deprivation does not affect smoking habits. But there are some factors, maybe socioeconomic factors, maybe living environment, neighborhood factors, education level, that can affect both the risk of deprivation and smoking. Now, other factors may also be associated with birth weight, let's say maternal height, but it will not affect, let's say, smoking or maternal deprivation. Now, also, like tax policy that I mentioned before would be an external factor. It can affect maternal deprivation because it directly affects their financial well-being. So now let's try to put all this convoluted, text into graphs. It's much easier to draw them than to list on paper in words. So let's start with the exposure, maternal deprivation, and low birth weight. Then we already discussed that diet might be in that causal pathway. So while this is a direct path from maternal deprivation to the outcome of low birth weight baby, this would be another path to arrive to it. So maternal deprivation of poverty causes poor diet, which in turn causes low birth weight. But that's not the only complication. We talked that age can have effect on both. So age can affect maternal deprivation. Older mothers will be probably less likely to be in higher poverty brackets. And that also can affect chances of having low birth weight infant. We also talked about smoking. So when we look at smoking, we know that it may depend on age. Smoking definitely can affect chances of having low birth infant. And there, as we talked, there are some unmeasured factors, and it wouldn't be known, let's say, in this study, that also affect maternal deprivation and smoking. But these are unmeasured confounders. There is another genetic component that we discussed, let's say maternal height, and that would affect low birth weight, but nothing else in this setup. And there is this tax policy, which is sort of an external factor which can affect maternal deprivation. Now, you also see this graph populated with things which we usually use, with the terms that we usually use when we discuss these things. So, for example, maternal deprivation would be called exposure. That's the outcome that we are looking at. So low birth weight is the outcome that we are looking at. Then these are confounders, age and smoking. Maternal height is not related to anything else, so we call it a covariate. And tax policy is just like an external variable. We sometimes call it an instrument. So then we start looking at the relationship. So this, there is a front door, what we call, that's the way how we can arrive directly from exposure to the outcome. That would be this path and going through the diet route. So that's what we call front door. Everything else, all the relationships leading from exposure of maternal deprivation to low birth weight will be called back door. There is a way to get there, but it's convoluted. So that's what we call back door. And tax and height are kind of nuisance parameters in this case, or factors, and we will not dwell on them too long now. So we have to control for all this and somehow investigate how we can arrive from exposure or to the outcome. So front door should be kept open because that's how we come from exposure of maternal deprivation to the outcome of low birth weight. It's either direct path or through the diet. So those are the ones that we focus on. But everything else has to be minimized, or their effect has to be minimized. So back doors always cause trouble when they're open. An open path is called a path where variables are allowed to vary. So you can see all kinds of things in there. A path becomes closed when at least one of the variables along that path is not allowed to vary or is controlled for. So how do we do that? We can use either study design to do that. So for example, if we want to eliminate smoking from this picture, we could just enroll non-smokers in our study. That would be controlled by design. It's not always feasible, and especially in observational studies, that's when we use statistics to control for that. I will not go into that today, but subsequent lectures will. So when we use statistics, we need to know what to account for and what to adjust for. What do we need to control? So when we look at this graph, you basically look at factors which are standing in like any relationship with exposure, the outcome, and make a list of those. So when you look at them, in those paths, we see age and smoking occurring everywhere. The measured confounder is there, but we don't know that. So we don't know the values, we will not be able to adjust for that. So these are the factors that we would use to adjust for factors. So when we look at it, we make a list of those adjustment factors, and we will use statistical techniques to adjust for them. So in summary, when we look at the average treatment effect, and that's the one we want to calculate in order to produce an estimate of the causal inference, it's very straightforward when we have randomization or controlled experiments. They eliminate selection bias, and then the outcome in treated and untreated individual will form the difference, which will be a good estimate of the average causal effect or average treatment effect. Now, when patients are not randomly assigned to treatments, and that's in particular the case in pretty much all observational data, the differences in patient characteristics between the treated and untreated groups will produce a bias. If you just do a simple and adjusted comparison and you compare the average observed outcome between treated and untreated group, one group may have been younger or healthier and thus had a good outcome as compared to the other group, and that was not accounted for if you just do a simple comparison. Then, if you deal with observational data, you can have direct and indirect path from exposure to the outcome. The best way to assess that is via those diagrams. So you can draw a causal diagram and think about it. And by the way, when you draw causal diagram and you make up a list of those nodes or variables that you are considering, two things are important. The arrows that connect them are very important, but arrows which you decide not to put them on the graph are also very important. Between the absence of an arrow between two things means that you will not consider it, or you think that it's not relevant to the phenomenon that you investigated. So now I mentioned that we adjust or control for these confounders that we observe in the path from exposure to the outcome. How do we do that? There are statistical methods which are designed to do exactly that. And one of the most popular ones is a propensity score. You will hear about it much more in the future lectures. And here is a list of the lectures that are coming up. So the two subsequent lectures in November and December will be on propensity score. The first one will talk more about the foundation for propensity score, why they work, how they work. And the December lecture will illustrate it in action on applied data sets. Then structural equation modeling is a big part of causal inference. So we have a lecture on that. And then mediation analysis will be also covered early next year. So mediation analysis will be exactly exploring this path. For example, when we look at maternal deprivation, direct relationship to low birth weight, and then there is a variable which stands in the path of it, such as diet. That's what mediation analysis explores and sees how the effect of maternal deprivation gets mediated by the diet in terms of the outcome of low birth weight effect. And at the end of the talk, I have a few references. Some are books, some are scientific articles, but they have very good overview of causal inference and various aspects of doing analysis for causal inference. I'm happy to take any questions that you may have.